diffuse hyperplastic goiter. You know that at the time of physiological stress, say during puberty, during pregnancy, during lactation, there is increased demand of the body to the thyroid hormone. So the thyroid follicles attain hyperplasia and hyperactivity to compensate for the body needs. Females get some thyroid diseases in a more percentage than males, say in Graves' disease, which is a primary toxic goiter. It's more common in female rather than in female. Then we transfer to the patient complaint. The patient is coming complaining of swelling in the frontal aspect of the neck. I don't like the terminology in front of the neck because this means that there is an empty plane between the swelling and the neck, but it is a swelling in the frontal aspect of the neck. It takes either globular shape, butterfly shape, or irregular shape. And then we go to the present history. Present history consists of two main items. The first item is analysis of the patient complaint. So the complaint, if it is a swelling, we can say that the swelling started since 3 months, 1 year, 3 years, and so on, with a either progressive course, regressive course, or stationary course. And it is of how many months or years or weeks or days in duration. We catch this point, which is the time of the patient complaint. So if it is a rapid, fast enlargement of the thyroid, anybody of you can tell me which is the most rapid enlargement of the thyroid gland? It occurs in cases of, hear me? Somebody of you can answer? We can share the discussion. You hear me?
Carcinoma.
Another opinion. Any other one can say another thing rather than carcinoma. There is some lesion which is more rapid than carcinoma of the thyroid, causing thyroid enlargement. Can you guess? Okay. Here there is a condition of the thyroid gland which is called hemorrhage in a cyst. And this gives a rapid onset. The patient can say it's occurring in about 1 hour or 2 hours. How it occurs? Already there is a thyroid cyst, and then there is a bleeding point in this cyst, the blood vessel passing in the wall. It undergoes spontaneous bleeding. So there is a hemorrhage into a cyst that may enlarge, and it may lead to a suffocation. You understand? So when you are asked which is the most rapid swelling in the thyroid gland, yes, it's hemorrhage in a cyst. يلي اللي الدكتورة قالته اللي هو carcinoma. Can you specify the type of carcinoma that gives a rapid enlargement of the thyroid? Yes, it's anaplastic carcinoma. But the other types, which are follicular carcinoma and papillary thyroid carcinoma, take so many months to increase in size. يبقى ده بنناقش ايه النقط اللي ممكن استفيدها even من analysis of the patient complaint. نقطة واحدة اللي هي الديوريشن بتاعته بقالها قد ايه. Then we can classify the etiology of the anatomical site. What are the possible causes? It may be a traumatic mass like an organized hematoma. It may be a benign neoplasm. It may be a malignant neoplasm. And it may be an inflammatory lesion. So I give some no leading questions to the patient. Is it associated with a history of trauma? And you write down whether positive or negative result is or is not associated with a history of trauma. Is there any systemic manifestations of inflammation, fever, sweating, headache, malaise, and so on? And then we resort to the malignant cause of thyroid enlargement or of a neck swelling in general. فبنبدأ ندور على اللوكوريجينال effect of malignancy. And the second is, yes, somebody is raising the hand. Okay. No. Like infiltration of the esophagus. So you ask about dysphagia. Infiltration of the trachea. You ask the patient about dyspnea. And if there is infiltration of the recurrent laryngeal nerves, ask about change of voice, recent history of change of voice. Then you think about the secondaries arising from the thyroid. The secondaries may, in some types like papillary thyroid carcinoma, go to the nodes, lymph nodes in the neck. وبالتالي هبدأ أسأل عن إيه؟ هبدأ أسأل على clinical evidence of other swellings in the neck. By other swellings, I mean enlargement of the draining lymph nodes of the thyroid gland. Some other types of carcinoma, like follicular thyroid carcinoma, gives its meats mainly through the blood. So I ask about bone swellings because it preferably goes to the bone, especially to the thin bones of the skull. If there is any scalp swelling or there is no scalp swelling. Liver and lung are rarely to be involved in thyroid carcinoma, but in late cases, it may give the mets to the lung. So I ask about chest pain, cough, dyspnea, hemoptysis, and the other evidence of chest involvement or pulmonary infiltration. Again, so present history includes two main items. These two main items are number one, analysis of patient complaint, and number two is interrogation of different body systems that may be related to the patient complaint. This swelling may be functioning, so increasing the secretion of thyroid hormone, thyroxine, L-trypsin, or T3 and T4 hormones. So we should ask about evidence of thyroid. يبقى أنا فكرت إنه الإيتيولوجي ممكن يكون تروما، ممكن يكون ديجنراتيف، ممكن يكون بناين تيومر، ممكن يكون مالجنان تيومر، ممكن يكون انفلاماتوري زي الموضوع اللي هو بيديني ايه حاجه اسمها thyroiditis or different types of inflammation of the thyroid gland. I hope you are following me. We shall discuss الملف الأولاني علشان نقدر نشرح الصور دي، ودي الحقيقة هتدينا قفزة لقدام اللي هي local examination of different neck swellings، ومنها نقدر ندخل ازاي من ال appearance of each swelling I can assess the time of the neck swelling in front of me. So the picture in front of you is a female, yes, is having a swelling, and this swelling lies in the upper part of the neck, included between the sternomastoid muscle and the lower margin of the ramus of the mandible. لو تشوفها in the live state هتلاقي انه The posterior part of the swelling is lying behind the sternomastoid. Anterior part of the swelling is lying anterior to the sternomastoid. So we give the characters of the swelling once again. It's in the upper part of the neck. It's included between the lower border of the ramus of the mandible and the medial edge of the sternomastoid. It's cystic inconsistency. هنرجع تاني بعد شوية لcystic inconsistency دي. إنما الفلويد اللي جواها الحقيقة ما هوش تنس قوي، فنقوم نشبهها بحاجة نقول إيه؟ It looks like a half filled bottle. A half filled bottle. طيب. Yes. Okay, thank you for the man who returned to the first. So this is what we call a branchial cyst. Branchial cyst. It feels like a half filled bottle. يعني شوية السيستيك سبيس اللي موجود الفلويد اللي فيه مش تنس قوي، تنس شوية بسيطة، عشان كده يشبهوها كأن في قربة جلد مليناها نص نص بالإيه؟ بالفلويد أو بالمية اللي جواها. نيجي بقى لكلمة سيستيك. طب أنا أي سيستيك سويلنج in the neck أو في مكان تاني غير النك بقدر أعرف؟ ما هو ده كلينيكال سيمينار، عايزين نكتسب فيه بعض الكلينيكال اكسبيرينس يعني. يس ابراهيم ريزنج ذا هاند.
دكتور بس معلش، هو حضرتك فين بالظبط عشان نتابع مع حضرتك؟
انا في السلايدز اللي مكتوب عليها differential diagnosis او هو PDF يعني.
الفايل اللي
اوكي.
حضرتك بعته لنا
اللي اتبعت على الواتس يا حبيبي.
في سلايد كام بقى معلش؟
ده اول واحده.
لسه في أول واحدة. تمام، ماشي شكرا يا دكتور.
اوكي.
تمام ماشي شكرا.
هي فيها اكس راي كده على اليمين وصوره عيانه على الشمال.
تمام.
ها.
اه.
اوكي يا حبيبي.
ماشي شكرا يا دكتور.
نرجع بقى نقول ايه. طب cystic swelling سواء كان in the neck او in the abdomen او in the thigh او اي حته تانية، احنا كلينيكالي بنقدر السيستيك سويلنج ازاي؟ شوف خليك معايا. لو السيستيك سويلنج ده كبير بقوم بعمل حاجه اسمها ايه؟ كروس فلاكتويشن تيست. يعني ايه كروس فلاكتويشن؟ يعني ايدي اهي.
دكتور مختار.
مم. ايوه.
معايا. I'm تامر يوسف.
يا تامر. ايوه.
Please sir speak in English because there is Malaysian people with you.
اوكي.
Okay,
اوكي.
thank you.
اوكي. So the cystic swelling may be known by what's called the cross fluctuation test. So I compress here on one line, say the transverse dimension of the swelling. If I compress by one hand, there will be expansion on the other hand. Reverse your hands in the perpendicular direction. If you compress with the upper, there is expansion to the lower. And if you do it in a reverse direction, it will expand on your examining upper hand. Is it okay? This test is called cross fluctuation. So I do it in the transverse direction and in the vertical direction. Here comes the swelling, the question. Why to do it in a perpendicular direction, in two directions, transverse and vertical direction? The answer is some structures in your body. All of you can follow me. If you put your palmar aspect of your hands in front of the thigh and do in the vertical direction, it will give positive cross fluctuation. But if you repeat it on the transverse direction, it will give no cross fluctuation. And that's the cause why we do it in two directions, a transverse and a vertical direction. For the cross fluctuation to be performed, you need a large swelling in order to show you the cystic consistency of the swelling. But if there is a small swelling and it's cystic like that in the picture in front of you, which is a branchial cyst, I cannot do the cross fluctuation. The surface area will not take my examining hand. So I will hold the swelling by the index and the thumb of the left hand. Then by the index finger of your right hand, you will press the central part of the swelling. So you may find that the central part of the swelling is the most yielding part. The most yielding part. And this test, this clinical test is called Paget test to prove that it is a cystic swelling. How it is interpreted? It's interpreted by the fact that your index finger of your right hand will feel that the central part is the most yielding part of the swelling. Hagar is raising the hand, I think.
دكتور صوت حضرتك واطي بس الصوت مش واضح ممكن حضرتك بس الصوت يبقى واضح شوية.
والله يا بنتي انا مقرب من اللاب خالص يعني. طب كده اوضح؟
كده تمام أحسن شوية.
طيب نجيب على المسافة دي. إلا إنه الكلينيكال انتربريتيشن في حالات هاجر تاني ريزنج ذا هاند. لسه مشكلة الصوت؟ أوكي. There is a simple exception for this Paget test, which is the what we call sometimes thyroid paradox. What do you mean by the thyroid paradox? It states that the more tense the cyst of the thyroid, the more hard it feels. Again, it's already cystic, it's containing fluid, but the fluid inside is so much so that the cystic swelling is tense. We can say the more cyst the swelling, the more hard it feels, the more solid it feels. Here comes a third example of the cystic swelling. I hope you note that in the big cystic swelling, we have diagnosed by cross fluctuation, and in the small cystic swelling, we used the Paget test. Any of them is a supported structure. There is something lying behind. There is a certain anatomical arrangement lying behind. But suppose that this is a dangling swelling, cystic swelling, which is having no posterior support. The evident example of this is a hydrocele, cystic swelling containing, yes, cystic swelling containing fluid around the testis. I cannot do the cross fluctuation. I cannot do the Paget test. So there is a special test for the scrotal cystic swelling. We call it bipolar fluctuation. Compress the upper pole, there is expansion in the lower pole. Compress the lower pole, there is expansion of the upper pole. تاني الكلينيكال كرايتيريا يبقى من المورفولوجي بنقدر نعرف تقريبا ايه التشخيص اللي قدامنا and معظم all of the head and neck swellings can be diagnosed as a spot diagnosis. So if you see this picture of a cystic swelling in the extreme upper part of the neck, partially under cover of the sternomastoid, partially in front of the sternomastoid, cystic inconsistency, This is a branchial cyst that arises from the branchial arch's remnants during the embryonic development. Another swelling arises in the neck that should be differentiated from a branchial cyst, which we call a caseous upper deep cervical lymph node. Caseous upper deep cervical lymph node. It gives the same picture in front of you, which is the like the branchial cyst. Even if you aspirate, you will find straw-colored fluid in both of the lesion, and you cannot differentiate except by microscopic examination, where you can find that the branchial cyst is containing cholesterol crystals, while the caseous lymph node does not contain these cholesterol crystals. Can you change the slide, please, from your computer? Change to the second one. Yes, sir. Okay. So head and neck swellings collectively, a number of masses that develop in the head and neck. We can say that it is a swelling, a growth, a tumor, a lump, or a bump. Some head and neck masses may be benign, some others are malignant. Change, please. Oh. Can you follow me with the pictures on your WhatsApp? Hello? Yes, Ahmed. Is it الصور مقطعة ممكن ترجعها تاني؟
هو مش انا اللي كنت مطلعها، بس واحده تقريبا.
طيب يا حبيبي. طيب تابعوني بقى على الايه الواتس اللي معاكم يعني. ايه؟
تمام.
انا هفتح من مصدر الواتس برضه اهو على التليفون. خليكم معايا دقيقة واحدة. هي بتحاول تاني ولا ايه؟ اوكي. ده تمام. نقدر نغير باللي بعديها اللي معانا. Okay, stay here. We have mentioned the fact that head and neck swellings can be diagnosed by first look or by spot diagnosis. So when you look for this picture on the right side, this presents lymphadenopathy. So if you find that there are multiple swellings in the neck, here, here, and here, so many lumps are found in the neck in the different anatomical sites in the neck, so this is a diagnosis of cervical lymphadenopathy. We can take an idea about the anatomical arrangement of the lymph nodes. We find that the transverse collar and there is a vertical collar. In the transverse collar, we can see the submental lymph node, submandibular, then comes the masseter coming in contact with the ramus of the mandible. Here is a lymph node which is a premasseteric lymph node. Above the parotid gland, there is a preparotid lymph node. In front of the ear, preauricular lymph node. And posterior to the ear is a postauricular. Lastly, you have on the mastoid process the mastoid lymph node, and lastly, the occipital lymph node. Again, the transverse collar of lymph nodes includes the submental, submandibular, premasseteric, preparotid, preauricular, postauricular, mastoid, and occipital. When we go to the vertical group of lymph node, here is the sternomastoid. On the upper point here is the upper deep cervical. Lower down the lower deep cervical. In between there is the middle. The longest section of the digastric muscle with the internal jugular veins, so we can call it the jugulo-digastric lymph node. The second inferior is the jugulo-omohyoid. It is at the point of meeting of the jugular vein and the omohyoid muscle. Then there is a group filling the posterior triangle of the neck that are called the posterior triangular lymph node. What we mean by this item is that if there is multiplicity, this multiplicity signs up the diagnosis of cervical lymphadenopathy. The second point in the cervical lymph node is that the lymph node can be rolled against the mandible. You can drag it above the ramus of the mandible upward and return it backward again. Okay? Can you change to the next slide, sir? Okay. Here is an enumeration of the famous head and neck masses or swelling that may be cyst, and we have mentioned before how to diagnose a cyst here by Paget test. Thyroid masses with its different types, vascular masses. What are these vascular masses? It may be a carotid artery aneurysm or a chemodictoma. What do you mean by a chemodictoma? It's arising from the chemoreceptors of the common carotid into an internal carotid and external carotid, where internally lies the chemoreceptors. So these chemoreceptors may be dictoma. Maybe enlargement of lymph nodes, as we have said, maybe inflammatory, like inflammatory conditions leading to lumps of the head and neck. You can give examples of these inflammatory masses like Ludwig's angina, which means diffuse cellulitis of the loose areolar connective tissue that's found in the floor of the mouth, may give an evident swelling. A parapharyngeal abscess gives an inflammatory swelling. A parotid abscess, submandibular sialadenitis. These are all examples of inflammatory masses. Okay. Next slide, if you can, please. Next slide. Yes. We return back to what are the possible symptoms associated with neck lumps, because I can assist in the diagnosis of the lump. If the lump is in the neck and persistent for more than 2 weeks, especially if it is not associated with any evidence of cold, flu, or influenza, and so on. Another group of head and neck masses like carcinoma of the mouth, throat, larynx, thyroid, lymphomas can appear first as painless growing neck lump that are lymphadenopathy. Okay, next one, please. Next one. Okay. You can pick from the history taking and from the clinical examination points that may help in the diagnosis. If you find that there is change of voice or hoarseness of voice, that there is infiltration from the thyroid gland to the recurrent laryngeal nerve. Look in the patient mouth. You can see swollen tongue. You may see a swelling in the floor of the mouth, like we speak later on. You may find blood mixed with saliva. That means ulcer of the tongue, especially carcinomatous ulcer of the tongue. Okay. Next one, please. Next. Okay. The patient to your right side, the doctor is examining the thyroid gland. So we return back to the main item of examination, and here we go to the local examination. When you see the back to the general examination of the thyroid gland. The preferred position is that you are on the back of the patient and the patient is sitting, the neck is completely bared, but you can also get your data from standing by the side of the patient or by standing in front or even in front of the patient. Now this is the preferred position of the examiner. What to do in thyroid examination? You put the palmar aspect of the two hands on the swelling like this. You can do like this, man. And then ask the patient to swallow. Deglutition, it means. If the patient swallows and you find that the swelling is deglutition, this is related to the cervical fascia. The thyroid is found in the thyroid capsule, and the thyroid capsule is a condensation of the cervical fascia. So the patient, when swallowing, the swelling will go up and down with respiration. That is the first step. What's the second step? The second step is to comment on the which loop is affected, or if the two loops are involved in a butterfly swelling. So the swelling is including the two loops and it depicts a butterfly appearance, or say it is a right loop only swelling. This swelling, it's global, it's irregular, it's firm in consistency, or soft or hard in consistency. Let me say something which is interesting. The soft consistency is like the lobule of your ear. You cannot describe more, but it is like the lobule of the ear. It's soft in consistency. A firm consistency is like the consistency of the tip of your nose. Thirdly, a hard bridge of. So when you examine a neck swelling, and we have said that the thyroid swelling is the most famous example of the neck swelling, you say is either diffuse, involving the two loops, or it's restricted to one loop, it's taking the whole loop, or presenting as a solitary thyroid nodule, and we say it's regular or irregular. Surface is regular or irregular, and then palpate the lower boundary of the thyroid gland. Palpate the lower boundary, especially when the patient is swallowing. and your comment is, I can access the lower boundary of the thyroid, or I cannot access the lower boundary of the thyroid. What does this mean? If you can access the lower boundary of the thyroid, this means that there is no retrosternal extension. If you can't, this means that there is a retrosternal extension. Okay, sir? Uh, Pinch the skin overlying the swelling, and your comment is either infiltrated, how I can pinch, or I can pinch the skin freely over the swelling. Look here for the groove in between the sternomastoid and the thyroid swelling. Here there is a groove, and it is preferred to for the patient to push by this side of the chin against your examining hand, and then assess the furrow between the thyroid and the sternomastoid. Is it empty or it's full by the swelling, which is full by a huge enlargement of the thyroid gland? Repeat your work on the other side. Here are two other clinical palpation signs I'd like to remember. The first is if I push the thyroid loop from that side and from that side against the trachea, if the patient experiences difficulty of respiration, dyspnea, or sometimes a stridor, this means that there is compression of the thyroid, enlarged thyroid on the trachea and the lower part of the larynx. This is sometimes called Kocher's test. Kocher test is one of the extra palpatory exam is to push the two thyroid loops against the trachea and notice if there is any type of dyspnea or stridor. Another clinical sign is that I put my fingers on the carotid on the left side and the fingers of the other hand on the carotid on the other side, and then palpate the carotid on the right side and on the left side. If I ask you if there is a tumor on the left side, which is actually infiltrating the carotid artery, the difference between palpating the carotid pulse on the two sides, you think will be in the number or in the volume of the pulse? Yes, I'd like you to share. Sir, do you hear me?
In the volume, I think.
Yes, it's in the volume. It can never be in the number of pulses because the number should be constant. But the volume will be lower amplitude on the infiltrated side and of normal amplitude on the sound side, or can say the healthy side, that here is the right side. This clinical test is called, yes, Barry's test. Berri, Barry's test. So I'd like you to remember two palpation tests done in the thyroid enlargement. The first test is the Kocher test, that's compressing the two thyroid loops against the trachea and search for evidence of respiratory trouble. The second is to palpate the carotid high in the neck here, and your interpretation is that if there is change in the volume of pulse on one side, that means that there is infiltration, or a very huge benign tumor without infiltration, but it is stretching. It's stretching the carotid artery, and so there will be change in the pulse. Still, we are still in the palpation in my clinical examination. Here in the suprasternal notch, I can assess centralization of the trachea. It's one of the methods of assessment of centralization of the trachea. If there is a huge swelling here on the left side, naturally it will push the trachea to the right side, and vice versa. The reverse is okay. So if I compress the right enlarged thyroid lobe, it will compress the trachea, so it will be shifted to the left side. I hope you are following me. Still, palpation in the neck in such a case is still deficient, because as we have discussed in the etiology of thyroid enlargement, the condition may be malignant. So your examination is not complete except after doing palpation of the transverse collar, the vertical collar, and the posterior triangle lymph node. I wonder if can I ask you in which type of carcinoma of the thyroid you will find enlargement of the draining lymph nodes? Yes, sir. Which type? Huh?
Papillary.
Yes, sir. Yeah. So we can agree with you that each type of thyroid carcinoma is having its method of metastasis. So a papillary thyroid carcinoma mainly metastasizes to the lymph nodes in the neck. Follicular carcinoma is mainly hematogenous, and these are the two main differentiated types of thyroid carcinoma. We have a very simple knowledge here. If I ask you how the thyroid tissue is drained into the lymph node, we can classify it to a central part of the thyroid and peripheral part of the thyroid. To start with the peripheral part, it goes up to the upper deep cervical lymph node, and it goes down to the lower deep cervical lymph node. Also, the middle deep cervical may be involved if the site of the primary tumor is in the domain of the middle deep cervical lymph node. Then comes the central group, including the isthmus and the medial aspect of the left lobe and the medial aspect of the right lobe. It will go to the prelaryngeal lymph node and the pretracheal lymph node. Upward to the prelaryngeal and downward to the pretracheal lymph node. And this pretracheal lymph node takes the terminology of Delphian lymph node, Delphian or Delphic lymph node. Okay. When you start palpation, don't put compression so much in the start. You do a what we call light palpation, because you may feel a thrill in cases of thyrotoxicosis, especially in Graves' disease, where the gland is soft and it's highly vascular. You can feel a thrill. This thrill, if you, in another step in your examination, which is auscultation, if you put your stethoscope on this vascularized gland due to AV shunting occurring inside the gland, you can listen to a bruit. So both terminologies, thrill and bruit, are the same, but the thrill is felt by light palpation, while the bruit you can listen to it by your stethoscope. Next slide, please, if you can. Okay. What are the keys of diagnosing head and neck masses? Still, we are in the clinical part of the diagnosis, so you should to study the skin overlying the swelling. This could indicate some lesions that are pigmented, like basal cell carcinoma and malignant melanoma. A patient complaining of persistent ear pain or ear pain that occurs during swallowing. It may be either infection or growth in the throat or growth in the posterior aspect of the tongue. This may be away from our subject today, that means neck swelling that are externally apparent to the examiner. Next one, please. Next, sir. Okay. Some of the radiological investigations of importance in diagnosing neck mass are the ultrasonography, and sometimes you are in need of magnetic resonance imaging. No more to know the titles, what to do, what types of investigation you can do. Okay, the next, in order to go to the other file of the thyroid. After ending this next slide of this, the colored file. Next. I hope I can change it from my computer. Okay. CT scan also, and the PET scan. It's of importance in diagnosing malignant lesions. You know that the PET means positron emission tomography. It's either known as PET or SPECT. That's the single photon emission tomography, another generation after the PET scan. The next one, please. Okay. Listen to me, this is of a very important interest in diagnosis of head and neck mass, and it has facilitated the diagnosis of head and neck mass, whether in the thyroid gland or in other sites rather than the thyroid gland. What is this fine needle aspiration biopsy cytology? It's done as an outpatient clinic. It needs no anesthesia. Here is the syringe used in this process, which is doing a continuous steady suction. Here is the needle entering through the skin into the neck lesion. You aspirate, then you change the site of the needle from the same entry. You can go in and out, in and out, and in this direction, in and out, in and out, in a fan-like manner, like a fan. You are allowed to enter and withdraw for 18 times in this fan-shaped manner. So there is a process of decreasing the fallacies that may be obtained from missing the lesion inside the mass you have. And it has been more facilitated by the use of ultrasound guided fine needle aspiration biopsy cytology, where the ultrasonographer can determine the suspicious point inside the whole lesion and then goes with the fine needle inside the suspicious part and do his inspiration. So this will take cells and not a core of tissue. Then go with these cells and preserve it. Here the preservation in cytology is made in absolute alcohol, not in formaldehyde as in case of tissue biopsy. First to aspirate, second fix in absolute alcohol, third stain. Naturally, the pathologist or cytologist will do this, but you should do it. You should know the knowledge of how to do a fine needle aspiration biopsy cytology. And then stain. Naturally, here the staining will be by cytological stain. That's either Papa Nicola stain or Ginsa stain. Then result will be cytology and not a histopathology. So the man can tell you that you are confronted with a benign lesion or you are confronted with a malignant lesion, nothing more. Benign lesion or malignant lesion. So we can collect the advantages of the fine needle aspiration biopsy cytology. That's an easy procedure. It's safe, it's rapid, it's inexpensive, and it can be done as a routine pre-surgical planning because it will tell you you are facing a malignant lesion or you are facing a benign lesion. Here comes an interesting issue in thyroid neoplasm, that is the follicular lesions of the thyroid gland. Here is some sort of defect, some sort of disadvantage in fine needle aspiration biopsy cytology if you are facing a follicular lesion. How? Follicular lesion may be either follicular adenoma or maybe a follicular carcinoma. Cytologically speaking, both of them will give cells that are cubical with basally situated nucleus and stain with hyperchromatic. But the differentiation between the benign follicular lesion and follicular carcinoma is not coming except by true cut needle biopsy because the differentiation between the two lesions is 2 points. First point is capsular invasion. You see by histopathology that the tumor tissue is invading the capsule. The second is angioinvasion. What do you mean? That the malignant cells infiltrate and come inside the blood vessels in the thyroid specimen that's found in the histopathological examination. So all of the points are advantages in the fine needle aspiration. We know that there is a more progress in the use of fine needle aspiration biopsy by the use of ultrasound guided fine needle aspiration biopsy cytology. We can say that it is safe, rapid, inexpensive, and can be used as a routine pre-surgical planning. المشكلة الوحيدة اللي موجودة قدامنا إن هي cannot differentiate between follicular adenoma and follicular carcinoma. This can be also managed by fine needle, by true cut needle biopsy that gives a histopathological specimen. So you can say that there is capsular invasion and there is angio invasion. Next slide, please, if you can. Yes. Okay, this is a case of submandibular lymph node in a young child. Submandibular lymphadenopathy. I can say that it may be branchial cyst according to the criteria we have mentioned before. Look here, if it's found more anterior than to this here in a submandibular triangle. So our diagnosis is between 2 points. It may be either submandibular lymphadenopathy and maybe submandibular salivary gland, either submandibular lymph node or submandibular salivary gland. I'd like you to share me in the differential diagnosis between the two lesions. Do you hear me? Can you share? Can you share with me the discussion? أحمد أو زهراء أو ياسمين. Oh, is it disconnected or you hear me?
blood and mucus.
The mucus comes in tongue lesions rather than in a submandibular lesion. Thank you for your thinking. Any other opinion? Any other? Look here. You should know this by heart. How to differentiate between a submandibular lymph node and a submandibular salivary gland. Naturally, the patient will be older than this little child. Okay? First, in the lymph nodes, usually you have what we call multiplicity sign. It's very rare to find a single submandibular lymph node. I might find one, okay, but usually it's either two or three lymph nodes, what we call multiplicity sign. A submandibular lymph node, I can roll it against the mandible. I can roll the lymph node mass against the mandible. A salivary gland can't. What's more important is I do the bi-digital examination. By the index finger of my left hand, I put it on the swelling, okay? On the swelling. By the index finger of my left hand, sorry, here's the right hand, I put it on the swelling. Open your mouth. I put the index finger of my left hand, it's also naturally gloved, yani. I put it on the floor of the mouth and then approximate the two fingers, the one outside and the one inside. If the finger inside feels the swelling, this is a submandibular salivary gland. If only the finger outside is a feeling finger and it's not felt from inside, so this is a lymph node. This is because the submandibular salivary gland is having a deep loop that lies in between the mylohyoid and the hyoglossus, so it's felt by the index finger of your left hand that's palpating the floor of the mouth. I hope this point is okay. Come on. Next slide, please. Next one. Here is again the lymph nodes. We have much knowledge about the lymph nodes. We have passed this. Another one. Another. Next. If you are confronted with benign swelling of the head and neck, they don't spread, they don't metastasize, it's natural, nothing new. But benign lesions can be serious if they impact nerves or exert pressure in the head and neck. They may be cysts, thyroid mass, vascular mass. Again, this has been said before. Another slide, please. Yes. If you are examining an infant or a child, please don't miss the congenital lesions or developmental cysts that are cysts and swelling arising from embryonic remnants. And here we are confronted with two main troubles that are the thyroglossal cyst and the second is branchial cyst. No need for this sebaceous cyst, it's outside our equation whatsoever. So the thyroglossal cyst, and we shall see photos of the thyroglossal cyst later on, and the second is branchial cyst arising from the remnants of branchial arches forming structures in the face. Another slide, please. Another or next slide. Here's the thyroglossal cyst. Okay. We can describe it as being a cystic swelling, and we have discussed how to diagnose a cyst by Paget test. It's lying in the middle line. It's moving up and down with deglutition. But to differentiate it from the thyroid swelling, we have a special clinical test. Ask your patient to open the mouth and then ask him to protrude the tongue, withdraw the tongue, protrude the tongue, withdraw the tongue. You find that this cystic swelling is moving up and down with this movement as well as with deglutition. يبقى it shares with the thyroid swelling in the fact that it moves up and down with deglutition, but it has a special test when asking the patient to open the mouth, protrude the tongue, withdraw, protrude, withdraw. It also moves up and down with this movement of the tongue. It's midline swelling in 75% or near the midline in 25%. Can you guess which anatomical site it's not exact in the midline? Yes, it's opposite to the laryngeal tip. Why? Because it's like this. If you put a ball, a small ball, on the tip of a triangular structure, it will not settle in the midpoint, but it will go either to the right or to the left. But here on cyroglossal cyst, the shift almost always is to the right side. Why the right side? You know that the story is the cyroglossal tract. This cyroglossal tract is the tubular structure that drags the thyroid along its way from the foramen cecum in the tongue at the junction of the anterior two-thirds with the posterior third of the tongue and brings it down to its normal anatomical position. Part of this tract will remain patent and it will undergo cystic degeneration to form this cyroglossal cyst. In anatomical dissection post-mortem, this cyroglossal tract is found to be shifted mainly to the right side on the tip of the larynx, but in the other sides of the neck, it's exactly in the midline. So this is the secret of this sentence is that it's occurring in the midline in 75% of cases, but found in 25% away from the midline. And we have mentioned that it's shifted usually to the right side, not to the left side. It elevates also on the swallowing and with also protrusion of the tongue and the treatment. We are not here interested in the treatment plan or in which type of surgery, but I'd like to mention a simple sentence that this tract is going from the cyst upward and then it's passing in relation to the central part of the body of the hyoid bone. It may be actually passing through, it may be passing in front, it may be passing behind the hyoid bone. So remember that the secret point in the management of a cyroglossal cyst is to excise the central part of the body of the hyoid bone, because you cannot guarantee the passage of the tract, the cyroglossal tract, through the central part of the body of the hyoid bone, so you should excise the central part. Okay, you understand? Okay, next slide. Next, sir. The branchial cyst, we have said in the picture in the first slide, this is less evident than the first, but it's anterior and deep to the sternomastoid, as we have mentioned. It's formed of remnants of incompletely obliterated branchial clefts and pouches It's painless. It starts in the young adults. It's occurring in the male as well as in female in an equal ratio, unilateral in the majority of cases. And we have said that there is one differential diagnosis, which is the caseous TB lymphadenopathy. Caseous TB lymphadenopathy. Can we get this next slide? Next one. Another branchial cyst. Okay, next. This is how to excise the branchial cyst. Really, it's not an easy job. It's having inflammatory adhesions on the periphery of the cyst, and you should excise the cyst as a whole. As we have said, it's not the site nowadays to discuss surgery of these lesions, but we are interested in the clinical interpretation and in the diagnosis of these cases. Another one. Yes. Okay. Another one. Next slide. Next, also next one, because I'm not interested in counting the sebaceous cyst in the subject today. Next slide. Yes, dermoid cyst. And here in the head and neck, it's a type of sequestration dermoid that may arise anywhere in the midline of the neck, but it's common in the suprasternal notch. You can call it the suprasternal notch of Bern. Burn, suprasternal notch of Bern or space of Bern. This is sequestration dermoid. As you know, the skin is developed in two halves, one to the right and one to the left. If some epithelial cells are sequestrated, they are losing their journey in forming the skin, and they are buried under the surface skin. We have a rule. An epithelium which is covered by epithelium will curl and form a cyst. Again, epithelium, if it is buried under another epithelium, it will curl and form a cyst. That's the idea of this, what we call sequestration dermoid. Sequestration dermoid. Okay, may arise in the midline of the neck, but the most common site in the neck and counted as a neck swelling is a dermoid that occurs in the suprasternal space of Bern or the suprasternal notch. Yes, another slide, please. Okay, ranula. This is a very interesting case in head and neck masses. So we are looking inside the mouth of a child or in a young adult. He is raising the tongue up. Here you will find a cystic swelling in the floor of the mouth. It gives a bluish discoloration because it's containing a mucus inside. This is called ranula. And the word ranula is derived from, it looks like the air sac of the frog. So a rana in Latin means a frog, as a swelling looks like a the air sac of a frog, so it was called ranula. It's arising in the floor of the mouth. If you can see, there are two structures that are stretched on the surface of the ranula. These are the ducts of the submandibular, the left from here and the right from there. They are stretched over the wall of the ranula. These are considered as mucus degeneration or myxomatous degeneration of minor salivary glands. You know that the salivary glands are three main pairs that are two parotids, two submandibular, and two sublingual. In addition, there are hundreds of salivary glands that are found in the mucous membrane of the cheek, in the floor of the mouth, in the mucous membrane covering the hard palate, the soft palate, and so on. So some of these minor salivary glands under the mucous membrane of the floor of the mouth undergo mucinous degeneration. That's called salivary glands minor of Blandin and Nun. What are the two structures that are stretched on the surface? These are the right submandibular duct and the left submandibular duct. And how to treat it? It causes space occupying. It's okay, benign lesion. It's having no harm, but it is a bulk formed inside the mouth. Can you excise the mass? Can you excise the ranula? You can. Due to two causes. The first, that the wall is very thin. You cannot dissect it completely. Second is the two structures that we have mentioned that are the two submandibular ducts. If you are going to excise, sure, you will injure or ligate the duct of the submandibular salivary gland. So the treatment here is done by what's called marsupialization. Marsupialization. Here we do de-roofing of the ranula. Then we suture the mucus membrane on the edge of the cyst to the mucus membrane, forming the floor of the mouth. After sometimes 1 or 2 weeks, this space will fill by granulation and the creeping of mucous epithelial cells from the two sides to cover the lesion and end it completely. So remember, you cannot excise for two reasons. It's very thin. The second, you have stretched submandibular duct, or you call it Wharton's duct, as we shall know later on in another seminars. You can only marsupialize. What do you mean by this marsupialization? This means de-roofing. Second step is suturing of the mucous membrane of the remnant of the cyst to the mucous membrane of the floor of the mouth. So remember, one of the swellings is ranula. Look here, suppose this ranula is finding its way downward into the neck, so it will dissect the plane in between the two mylohyoids and it will appear in the neck. So in such a case, it's called dissecting ranula or plunging ranula. But plunging means that it is sometimes inside, sometimes outside. Dissecting means that it's found outside and it is inspected as a swelling in the neck. It occurs originally from a ranula, but it looks like a hernia which finds a space in the raphe between the two mylohyoids, and so it will present in the neck. Removal here طبعا in this slide is not correct, so it is marsupialization and not removal. Remember the word marsupialization. So next slide, please. I'm waiting for you. The slide after the ranula. Another one, because this is a repetition of some infections that come in the lymph nodes. Lymphadenopathy of tuberculosis or psychosis or cat scratch disease. There's no site to discuss such things. Next slide. As I have said, we are interested in the picking up clinical knowledge as a clinical seminar of neck tumors. Another one, because this is a parapharyngeal abscess I'm not interested in. Neoplastic lesions, again, may be either benign or malignant, but here, uh, before we leave this file to the other file, I hope you return back to the, on your telephones, not change here, to the thyroglossal cyst. So if this thyroglossal cyst is going to be infected, it will form a thyroglossal fistula. So a thyroglossal fistula is an acquired lesion. It can never be a congenital lesion. You will find an opening in the midline, which is oozing either mucus or mucopurulent fluid. And if you hold above the opening, you will find a thickened tract. Ask the patient to open his mouth, protrude the tongue and withdraw the tongue, and you are still holding the tract. You will feel a special tugging sensation, what we call a thyroglossal tug. When you inspect the external opening of the fistula, you find that skin overlying the skin over the external opening is dangling down than the inferior skin. It looks like as forming a cover or a hood. So it's called a thyroglossal hood. How can you explain the formation of a thyroglossal hood? Skin here is not touched by the cerebellar fluid superiorly, but inferiorly there is continuous contact with the cerebellar fluid. So it's always inflamed, always fibrous, and so there is deficiency of growth here. But there is ordinary growth there above. So it will form a hood like this, while that is short inferior skin. Again, in the thyroglossal fistula, there are two clinical signs. The first clinical sign is what we call a thyroglossal tug, and you say it's a special type of feeling. I can call it thyroglossal tug and the thyroglossal hood. You may be asked what is the cause of this hood. This is because the skin superior to the opening is of an ordinary growth, while the skin inferior to the opening is having repeated inflammation and repeated fibrosis. Again, remember in the thyroglossal fistula, the following 3 points. The first point is that it's an acquired lesion, it's not congenital, because it was first a thyroglossal cyst, it becomes infected, and it either opens spontaneously or it's incised by the surgeon. So it changes into a fistula. This fistula is acquired. Remember two clinical signs that are the thyroglossal tug and the thyroglossal hood. Okay? Next one, please. Okay, next. لحظة. Okay, another one. Another. Okay. Can you give me the file of the thyroid, which is the black and the white one? Here is quite enough. There is nothing new in this differential diagnosis of head and neck masses. We return to the thyroid. We have discussed we began in the history. Still, there are some points in the history taking. The other file coming on you for you in the WhatsApp. There is another file. Yes. Or you can follow me in the on your telephone. Yes, you cannot raise the other file. I hope you are connected still. Hello? الو
هو مفيش فايلز
يس
يا دكتور.
دكتور.
كان في فايل تاني جالكوا على الواتس.
في صور بس مفيش
ايوه
فايل.
الصور يا سيدي اللي هي اولها الهيستوري تيكنج اوف ثايرويد وكده. اه لقيته ولا اشوف من عندي ونتكلم فيه؟ انا بعته للرقم واخره 98.
هو بس الصور مش بالترتيب فاحنا مش عارفش.
مشكلة، إذا تقدر تطلعها على الكمبيوتر طلعها. مشكلة، إحنا ننقي منها اللي إحنا عايزينه.
طيب ماشي.
أوكي أنا معاك، ولا أي مشكلة، إحنا بالليل ما عندناش مشكلة. اللي هي في أولها رسمة كده الأناتومي أوف ذا ثايرويد، وبعدين الشيت أوف ذا هيستوري تيكنج. على بال ما تطلعها نبدأ نتكلم. إحنا كنا وصلنا للبيشنت كومبلينت، بريزنت هيستوري مش كده؟ بعد كده هنقول باست هيستوري. الباست هيستوري هنسأل فيه عن، أيوه برافو عليك، اللي بعدها مش طالعة طيب تابعوا معايا على التليفون بتاعكم وما ترهقش نفسك. اوكي يا ابني؟ تابع على التليفون بتاعك. um, we come to the completing the history taking. Past history, I say that there is past history of surgery either in the neck or in the another parts of the body. In the neck, it will be of interest to know that the case you are confronted with is either a fresh case or it is a recurrent case. A fresh case or a recurrent case. No problem. Follow me on your phone, on the WhatsApp that has been shared by your colleague. And we'll speak. I hope you are listening to my voice and see the camera. And follow me on the pictures on your phone. We ask about past history of drugs. Why to ask for drugs? This patient may be prepared to operate on a case of Graves' disease or thyrotoxicosis. So he is taking either antithyroid drugs like carbimazole or cyarazole. He may be taking Logels iodine. Yes, very good. So yes, this is the drugs received as a preparation. And some drugs are goitrogens that the patient takes these drugs, he may develop enlargement of the thyroid, like the carbimazole, para-aminosalicylic acid. So many drugs may cause enlargement of the thyroid gland. So it's important in the past history to ask about drugs. Can you give me follow the picture? Family history. بعديها family history. If it's found يعني. I can ask the patient, is there any other similar conditions in your family or not? So there are thyroid diseases that are familial. They are running in families. And this is mainly medullary thyroid carcinoma. Medullary thyroid carcinoma. Because medullary thyroid carcinoma may be sporadic and may be familial. So when I ask about other members in the family, this is the one, following it. No problem. Follow me in your phone. Don't disturb yourself by loading it on the computer. It is the same slide, history of intake of drugs. Never mind, follow me on your phone. Uh, Another important thing in taking the family history is this hormonogenetic goiter. This hormonogenetic goiter. Look here, what do you mean by this hormonogenetic goiter? Is it stopped or okay? سامعيني؟ الو؟
اه يا دكتور سامعين.
تمام يا حبيبي. تابع معايا في التليفون بتاعك على الواتس، ما تشغلش بالك بقى بتطليع الصور يعني، اوكي؟ يبقى اذا family history is having two things that are important. First, the familial type of medullary thyroid carcinoma, and the second is this hormonogenetic goiter. What do you mean by this hormonogenetic goiter? This hormonogenesis, you know that the thyroxine formation is a enzyme-dependent biochemical process. It depends upon enzymes. If there is familial deficiency of 17 dehalogenase enzyme, it will not complete the formation of thyroxine. The gland will be enlarged because it's trying, and there is no formation, so it will enlarge in size. If this condition of this hormonogenesis is also associated with congenital deafness, it forms a clinical syndrome which is called Pendred's syndrome. So again, why I ask about family history of similar conditions? Twofold. Number one, the familial type of medullary thyroid carcinoma, and the second is this hormonogenetic goiter. What's this hormonogenetic goiter? It's enzyme defect, congenital defect of 17 dehalogenase. The thyroid gland tries to form, there is no formation. So it enlarges. There is goiter, enlargement of the thyroid gland. If this same condition is associated with congenital deafness, it forms a clinical syndrome which is called this hormonogenetic goiter, or it's called Pendred's syndrome. I'm sorry. That about family history of the thyroid note taking or case taking. The second thing in the diagnosis is the general examination. The general examination, I will interrogate the body from above, from the hair down to the toes, searching for evidence of thyroid disease. So in the pictures on your WhatsApp, you will find the illustration of the eye changes. You will find these eye changes in cases of Graves' disease or primary thyrotoxicosis, where normally the upper eyelid is covering 1/6 of the superior limbus of the cornea. Yes. While the lower eyelid is tangential to the lower limbus. So if I find that there is sclera appearing between the upper eyelid and the superior limbus. I can call this lid retraction. If I find it below, this is exophthalmos. But if fine sclera is apparent both in relation to the superior limbus and in relation to the inferior limbus, this is called severe exophthalmos. You'll find a strip, transverse strip. There is a drawing of the eyelids and the cornea with its superior limbus and the inferior limbus. From this drawing, you can assess, is it? Yes, it is. The one before. It's not appearing. Yes, sir. So follow me on your WhatsApp. The first is normal. The second is lid retraction. Or the second here on your photos is exophthalmos, lid retraction, and severe exophthalmos. Evidence من الجنرال exam. You will find a photo also on your WhatsApp where there is redness and edema of the conjunctiva, what we call chemosis of the conjunctiva. It occurs also in primary thyrotoxicosis or in Graves' disease. You also find another photo with a swelling in the scalp, a large vascular swelling in the scalp, which was metastatic follicular carcinoma of the thyroid. Metastatic. You find another one with red thickened patches on the leg, on the anterior aspect of the leg, which is a pretibial myxedema, also found in cases of primary thyrotoxicosis, or as we have said, Graves' disease. These are the points to be picked up in the general exam. Yes, this is a pretibial myxedema. Very good, sir. Another one, pretibial myxedema, as you see. It's evident in Graves' disease or primary thyrotoxicosis. Can you get another? Okay. Oh, difficult because it's, I think it's not PowerPoint. So, okay. You may find clubbing of the fingers, and in thyrotoxicosis we call it thyroid acropathy. Thyroid acropathy. It's clubbing, okay? But in Graves' disease, it's called thyroid acropathy. And can you get other pictures? Okay. After getting the general examination, you have to do a chest examination, a heart examination, and abdominal examination. They are also related to thyroid enlargement because in the chest examination, yes, this is the thyroid acropathy. Okay. By the way, I'd like to ask you a question. What do you mean by clubbing of fingers? Anyone can answer me? What do you mean by clubbing? Oh,
It looks like the golf club.
yes, it looks like, but what it is? I'd like you to give me a definition of clubbing. It's obliteration of the angle between the nail and complete. It's obliteration of the angle between the nail and nail fold. The area immediately behind the nail is called the nail fold. It's covered by skin, nail fold. So if I draw a line on the surface of the nail and another line tangential to the nail fold, it will make an angle with the nail. This equals about 15 degrees. So the first degree of clubbing is obliteration of the angle between the nail and nail fold. Okay, this is an angle, so it has two sides. The two sides are the nail and the nail fold. Never forget it. What is the definition of clubbing? It means obliteration of the angle between the nail and the nail fold, because each angle, as you know in geometry, is having uh, two sides and one angle. So the two sides, including the angle in between, are the nail and the nail fold. Okay? Can you get another photo? If not possible, we can complete from our WhatsApp. Okay. So you have got the patient from his hair down to the toes to search for evidence of thyroid disease, whether it is a benign lesion, it's secreting lesion like Graves' disease, or secondary thyroiditis, a malignant lesion giving a swelling in the skull. You have the picture of a patient is having a very huge swelling of the skull that was a myths from follicular thyroid carcinoma. Why I do an abdominal examination? Because in some cases of thyroidotoxosis, I can find that it's the problem is in uploading, because it's not apparent here. So yes, 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 but it turns rapidly to a nonsense. Okay. Uh, You examine the patient in the general examination, stating the basal parameters first, the pulse, temperature, and the blood pressure. The pulse, you find that there is tachycardia, and you may find water hammer pulse. These are found in cases of primary thyroidotoxosis and also in secondary thyroidotoxosis. Tachycardia, you may find the galloping rhythm of heart failure, because as you know, thyrotoxicosis may be a cause in irreversible heart failure, except when you correct the thyroid status. When you see the patient, you describe that he is sitting quiet, or is irritable, is cooperating with the examiner or not cooperating. Pulse, temperature, and blood pressure. We have stated the pulse. In cases of thyroiditis, the blood pressure. When you find that there is thyroid swelling together with hypertension, this may direct your attention to medullary thyroid carcinoma, the familial type, as it may be associated with multiple endocrine neoplasia syndrome. It may be associated with pheochromocytoma and medullary thyroid carcinoma. So take care of your blood pressure, search for pallor, jaundice, cyanosis, swelling is in the scalp. You have seen the picture of skull knits, eye signs, thyroiditis, we have observed it, pulsating congested neck veins that may occur in thyrotoxic heart failure, tongue tremors, hand tremors, water hammer pulse. Next slide, you can. Then we go to the local examination. The local examination includes the items, inspection, palpation, percussion, auscultation. Inspection naturally will be done from the frontal aspect of the neck. And you describe what you see. I see a swelling going up and down with deglutition. It's a butterfly in shape, or it's an isolated lesion, globular with round edge, no scars, no sinuses, no evidence of inflammation of the overlying skin. When the patient swallows, I can see the lower boundary of the mass or of the swelling, scars of previous operation present or not present, palpate from behind as you have seen before during examination of the thyroid gland and confirm what you have seen by inspection by your hands and describe the palpation. Never forget to palpate the draining lymph nodes, the furrow in between the thyroid and the sternomastoid, the draining lymph node, the lower boundary. Is there a retrosternal extension or there is no retrosternal extension? Never forget two special palpation tests that are the Kocher's test and the Beres test. You remember? Yes, Kocher is compression of the two loops against the trachea, and Berry is palpation of the upper part of the carotid pulse. You may find a deficiency in the volume that may be found if there is infiltration of the carotid or very huge thyroid swelling that's stretching and attenuating the carotid artery. Then we come to the percussion. I don't percuss the thyroid itself, but I will percuss over the manubrium sterni. If you find that there is dullness in percussion of the manubrium sterni, together with no accessibility of the lower boundary of the swelling, this means that there is retrosternal extension of the thyroid. Lastly, auscultation with your stethoscope by the diaphragm. Don't exert so much pressure. Put it lightly on the thyroid. If there is thyrotoxicosis with highly vascular thyroid gland, you listen to a bruit, and only palpation you have felt a thrill. We have discussed some investigatory methods, and we have said the K diagnosis in the thyroid and in the neck swelling in general is neck ultrasound. Number two, the fine needle aspiration biopsy cytology. In special situation, we may be in need of more advanced investigation like CT, MRI, or the PET scan, especially if I am diagnosed by fine needle aspiration biopsy cytology malignancy, and I'd like to assess if there is infiltration of surrounding structures of the infraoid muscles, of deep structures, esophagus, trachea, and so on. I have to resort to another advanced investigation. Don't miss the point of fine needle aspiration biopsy cytology. Its accuracy is added to by the use of ultrasound guided fine needle aspiration biopsy cytology. It gives you cellular diagnosis. It's stained by cellular stain. It's an easy process. It does not need anesthesia. But one thing in the thyroid is the follicular lesion where you cannot differentiate between uh, uh, adenoma and carcinoma, follicular adenoma and follicular carcinoma. This needs the histopathology in order to show you angioinvasion and capsular invasion. I think we have merged the two settings together. The first was about how to examine for neck swelling, and we assumed that the thyroid means the main clinical examination in the neck swelling, and then comes the second, which is giving an idea about the common neck swellings that need differential diagnosis. So comes the clinical seminar on differential diagnosis of neck swelling. I think it's okay, and I'm waiting to listen to any questions, anything that's not illustrated quite enough and you need explanation of it. Yes? Sir, any questions? Ahmed, Mariam, Yes, meme. Any one of them is having questions? بيقولوا لي إن you are still in contact.
No, thank you, doctor.
Thank you. You have no questions? Anything not illustrated? I can go. Okay. Goodbye, and I hope in the next seminars there will be a more electronic arrangement, that the troubles we have faced today will be finished, inshallah. Okay, bye bye.